Hello, welcome to Asmiha Corner 2024. My name is Anindita Primiari. I am one of your hosts in this year's Asmiha Corner. Today, we are very fortunate to have the opportunity to discuss a very interesting topic with Professor Lynette. Professor Theo is a senior consultant at Department of Diagnostic Imaging, National University Hospital, and also an assistant professor at the Yong Lu Lin School of Medicine, National University of Singapore. How are you, Professor Theo?
Yes, I'm very excited to be here. And on behalf of the Asian Society of Cardiovascular Imaging, I would like to thank my hosts for inviting me to such a lively and vibrant conference. You can see many people around, and it's very exciting. There are many booths, and the topics discussed at all the plenary sessions and all the poster sessions even are very interesting.
Thank you very much for traveling all the way from Singapore to here. Now let's dive right into your topic of expertise, which is the latest advances in cardiac imaging. Professor Theo, could you share your insights on why cardiac imaging has become so crucial in modern cardiology?
So cardiac imaging, as we all know, starts from echo. Echo is very important. It is, the basis of cardiac imaging. And, nuclear medicine is something that we can't ignore as well. And although I'm a radiologist, I know how important these two modalities are. And these form the foundation of cardiac imaging. CT has emerged as a very important modality for screening of coronary artery disease. And we all know, based on the 2017 NICE guidelines and the 2018 ESC guidelines, we all know that CT coronary angiogram is now the first-line investigation for stable chest pain. And this includes stable chest pain secondary to coronary artery disease. And as a radiologist, of course, I cannot not speak of the advances in hardware in regards to CT. And we all know that, almost 10 years ago, we started off with dual source imaging, and this has, exploded into a third generation dual source CT scanners. Our other vendors, have also done a very good job with single source wide array CT scanners, giving us sub-millisievert doses. But of course, now everybody is talking about the photon counting CT scanner, which further decreases the dose. And these scans can also subtract coronary calcium for us on the images. And as we know, coronary calcium is no good for the evaluation of luminal stenosis.
Wow, that's very exciting news about the advances in cardiac imaging. Personally, what is your favorite modality of imaging, the latest, in the most exciting advances in cardiac imaging technologies?
I think every single modality has got their strengths.
Yes.
Let's even talk about echo, for example. Now, echo strain imaging is big in echo, and everybody is very excited about left atrial strain. For for CT imaging, of course, we talk about photon counting CT scanner, and of course, you cannot not talk about CT myocardial perfusion.
Yes.
But personally, in my institution, we are trying not to cannibalize our MR myocardial perfusion service. So in my institution, we offer, of course, nuclear cardiology, MPI, and we offer magnetic resonance myocardial perfusion imaging. I've spoken about CT, now let's talk about MR. MR has evolved tremendously, and since I was a fellow at the Royal Brompton in 2006 till now, it has also improved by leaps and bounds. We started off with cine gradient echo imaging, we moved on to late gate enhancement, we moved on to MR myocardial perfusion, and now we are moving on to parametric mapping, which does not require contrast.
Wow.
And this can give us very detailed evaluation of the myocardial tissue, be it in myocardial edema, inflammation, and myocardial fibrosis, for example, in hypertensive heart disease and in hypertrophic cardiomyopathy. And we move on all the way to the infiltrative cardiomyopathies, for example, sarcoid, as well as amyloidosis as well. So now MR, you can look closer and delve deeper into tissue characterization. And this is, a win-win situation for everybody. And for me, I believe that it doesn't matter who reports MR or even CT for that matter. It could be a radiologist, it could be a cardiologist. As long as you're well-trained, and you're interested in the subject topic, you're interested in, making your scans good, and you're interested in optimizing your scanner, and you're interested in giving a good report, I think these are the two most important things that matters.
So everybody is welcome to learn and train.
Yeah, everybody is welcome to learn and train.
Yeah.
As long as, you're interested.
Yeah.
And, whatever it is in cardiac imaging, you need to know that multimodality imaging is important, and you need to go back and correlate with the clinical history and with other investigations. I think, this is the most important thing for cardiac imaging, and that's something that everybody needs to know. It is not that you put the patient in a black box, for example, the CT scanner or the MR scanner, you're going to come up with a diagnosis.
Yeah.
You need to correlate this still. You need to still go back to basics. Whatever it is, we are still physicians. We need to go back to basics and, evaluate your patient by the history, by the clinical examination, and by your ECG, and by all your more basic imaging modalities like echo, for example.
Yes, I'm interested with a parametric mapping, which will be your topic for today's session later at 1:30 p.m. Right? Could you explain a little bit the basic principle behind this technique?
So, parametric mapping, dwells into the basic principles of MR, which is T1 and T2 weighting. So parametric mapping, as you know, does not require contrast. So it is very, very good for patients who have renal failure, for example.
Okay.
T1 mapping is very, very good. So T1 mapping, the basis of T1 mapping is the relaxation time of your myocardial tissue. So this one relies on the longitudinal relaxation of the longitudinal magnetization.
Yeah.
So it's easy to obtain, but the only problem is that the guidelines and consensus statements will tell you, you need to get normal ranges in your institution. Because the problem with T1 and even T2 mapping for that matter is that it is very sensitive to the environment.
Yeah.
And the guidelines will tell you that you need to get normal ranges in your institution. You need to scan, healthy individuals of various age groups and various sexes to be able to come up with a normal range in your institution, because this will be unique to your scanner.
Okay, so we have to put a lot of patients to the mapping first to have the data. Is that right, Professor?
Normal range. But I mean, to be honest with you, if your service is so busy, after a while, when you scan your clinical patients, you will clearly also have some normal patients.
Yeah.
And you will get a feel as to what is the upper limit of normal for your scanner, both be it for T1 and T2 mapping.
Yes.
And to be honest with you, there are now many meta-analyses that have come out, giving us fairly reasonable T1 and T2 mapping ranges, as well as the extracellular volume normal range.
Wow, that's very interesting.
Yeah, so it's good to just read up the literature and to compare your values with that of the other institutions.
Okay, that's very interesting. So I assume that is the limitations and challenge. Is there any more limitations regarding the parametric mapping for now?
I mean, of course, there's a time penalty.
Yeah.
Right. Already a cardiac MR takes between 45 minutes to 1 hour.
Yes.
You throw in parametric mapping, for example. You throw in parametric mapping T1 and T2. What's going to happen? You're going to increase your scan time.
Yeah.
And your radiographers are going to get a long face.
Yeah,
okay.
Sure.
The other thing that I want to add about parametric mapping is that you are now going to get a value. You're going to get you're going to get a quantitative number. This is as opposed to in the past where we use our eyeball.
Yes.
We use our eyeball to see, the extent of myocardial involvement.
Yeah. So it's just qualitative eyeballing, no more qualitative
eyeballing.
Parametric mapping.
Yeah.
Okay.
Now it's quantitative. There's a number. You can put a number to it now.
Yeah.
And but the problem is that if your patient goes in your scanner in Surabaya, the T1 value could be different from a scanner, let's say with the same condition, and the same patient goes to a scanner, say in Jakarta, the number could be the quantitative number could be different, and that's because we need to consider things, the environment, for example, the humidity, and even what Tesla your machine is. So that's these are the issues that you need to consider.
Okay. Well, what do you see as the future of parametric mapping and other similar advanced imaging techniques in the next decade? Maybe will it be available in more centers? Maybe here in Indonesia, one of our biggest problem is, of course, the cost.
Yes.
Yeah.
This is also the case in Singapore as well. And to be very honest with you, the cost of MR scanner is 20 to 25% the average monthly income for a Singaporean, and this
Even
is the
for
subsidized
okay.
cost.
Yeah.
So it's not to be taken lightly, the cost of the scanner. For the future of parametric mapping, what I see is that parametric mapping has got a very, very high chance of replacing leg gap enhancement to look for myocardial fibrosis, for example, in hypertrophic cardiomyopathy, for example. And already a study by the Oxford group has already shown that this is a possibility.
Wow. So that was a very interesting and refreshing session with our expert here. Thank you, Professor Theo, for your insight.
Thank you for your hospitality.
Yeah.
And
please do like and share this video to your fellow cardiologists and clinicians. See you around in another episode of Asmiha Corner. Bye-bye.
bye. Thank you.